Very happy to reintroduce Randall Schapiro, Dr. Randall Schapiro.
Thank you, Alan. It is with a bit of fear and trepidation that I stand in front of you today to talk about what I have to talk about. In my life dealing with multiple sclerosis, I think I have lectured on virtually every topic that could be thought of in multiple sclerosis, from deep immunology to sexuality to whatever you can think of I've had to speak on. But nobody's ever asked me to talk on healthcare before. And so this is a challenge. And I find that when I talk about healthcare with my friends and family and others that are interested, I get very emotional. And the voices begin to rise, and I can feel the tension in my voice. And so I'm going to try very hard not to do that.
Not to get on your
Not to
soapbox.
stay calm and cool. We'll see how long that lasts in this deal here. So I like the topic that was given me, the choppy seas of healthcare. I have some questions that I want to ask you. How many of you feel that healthcare should be appropriately provided to all citizens in the United States who need it without financial issues? Okay.
I do.
Okay. How many feel that they should pay for health care out of their pocket when they need it?
Yeah, I do.
How can you? Yeah, okay. No, most of you don't seem to. Some want to pay for it out of their pocket. How many of you have that kind of money to pay for it out of your pocket?
I think we should be responsible.
You may feel like you want to pay for it, but how many think that the insurance system is simple today?
Down.
How many think healthcare should be run as a business?
Yes.
Okay.
No.
How many would like to see universal health care for U.S. citizens, even if their taxes would go up to pay for it?
Yes. Yes.
How many see this as an appropriate political issue?
Yes.
Republican, Democrat?
No. Yes.
Okay. So, you know, it's a very mixed crowd, which is the way it is, I guess, in life. I guess most of you sort of agree with what I think when I see the hands going up. But quite frankly, I don't know why this is a political issue. I don't know what health care has to do with being a Republican or being a Democrat, but like everything else, it has become a political issue, very much one, even though I don't see the point of it all. I want to talk about the beginnings of our modern health care system because I was around then. I was there. And it started with a physician. His name was Paul Elwood. And Paul Elwood was a Minnesotan. And Paul Elwood was a neurologist. He was also a physiatrist, a rehab doctor, and a pediatric neurologist at that. And he has been sort of the father of the health maintenance organization movement, which started around 1970. Health maintenance organization, that sure sounds like a nice way you maintain your health, but it had very little to do with maintaining health. And it spawned off other things, such as preferred provider organizations, where groups of preferred providers, doctors, got together and contracted with insurance companies to provide service. And then there were independent provider organizations, and then that moved and evolved into managed care. And then Paul Elwood in 1997 said this was a failure. His own movement was a failure because it had become a business. And I don't know whether your memory is the same as my memory, but one of the issues in healthcare as the costs were rising and rising was, I kept hearing, if medicine were treated as a business, we could get control of the costs. All we have to do is to treat it as a business. Then you have the business issues that come into play. But who is really to blame for the current healthcare conundrum? I mean, you can turn on Fox News any day, any moment, and you'll see who is to blame for today's healthcare crisis. He was born in August of 1961. When this started, he was 9 years old, and yet he's to blame. Quite frankly, he had nothing to do with any of the thing that I'm going to talk about in the next few minutes, and then we'll get into where he comes into play. But he is given the blame for everything because people can't separate wheat from chaff. They can't separate managed care from affordable care. I'm sorry, Mr. Jones, but your HMO does not pay for enemas. I'm going to have to slap the shit out of you. Is medicine a profession? You know, as a doctor, I'd like to tell you that I believe all physicians see medicine as a profession. We went into it with the idea of being a doctor, not a business person. We went into the idea of practicing medicine. If we didn't, it's too long a road to go to become something else. I've seen some physicians who wanted to become medical reporters go through all medical school and then become journalists, but that's the exception. Most physicians really want to be physicians. They want to be treated as a professional. They want to make professional decisions. They don't really want this to be a business, but it became a business because of the controls and constraints that were put on and by the politics that were played. As managed care became stronger and stronger to try to get the economy down, medicine became a business. And now I hear the strangest things, because if a doctor acts like this is a business, people don't like it. Patients don't like it. I keep hearing, oh, he ordered that MRI because he has an MRI machine, or he has this infusion because there's an infusion center. This is a business, and nobody likes that. On the other hand, if a doctor doesn't treat his profession as a business, I can tell you right up front that that doctor will go out of business and not be able to practice. So we've got this terrible conundrum for the professionals that are involved in the middle of all of this. Do we treat this as a business and stay practicing, or do we treat it as a profession and go out of business because we don't have the capability to bill and make the proper money to stay afloat? Managed care has gone through several different organizational groups. Kaiser's probably the best and most organized of these. Group Health in Minnesota also did this early on. Try to manage the care of people with diseases and people without diseases as well. And then the floodgates opened, and there were designated networks of hospitals and physicians, and every city now has these networks and of hospitals and physicians. Utilization review, looking over your shoulder of what you do, how you do it, when you do it. Do you do it properly? Disease management, case management. It sounds pretty good, doesn't it? Case management, disease management, but it's all been based on cost, not based on actual needs. Not entirely. Needs come in there, but costs also do. It becomes really a conveyor belt. I got to find a new HMO, as people are treated this way. I really like this Doonesbury commercial. The guy says, "It's my own fault. Did the skiing. No one should be skiing at my age." And he says, a lot of fluid in there. So what are we looking at? Well, I don't know yet. Could be an anterior cruciate ligament problem. What's your plan? Well, I'll do an anterior drawer test first, and then probably a full arthroscopic. Overkill. You should just do an x-ray. Oh yeah? Well, if you don't like my call, why don't you do the examination? Fine, I will. Excuse me, yes? Who are you? Your insurance agent. Does that hurt? And in a way, that bit of sarcasm is very truthful.
Very real.
Very, very truthful, as we'll get into. We are living in an era of evidence-based medicine. Evidence-based medicine. You can't be against evidence-based medicine. That's like being against God, motherhood, and apple pie all at the same time. Physicians truly believe in evidence-based medicine. Neurologists particularly believe in evidence-based medicine. But medicine is more than just evidence. It's more than just studies and studies and studies. There's an art to the practice of medicine. Whether it's laying hands on somebody, or whether it's simply talking to somebody in a kind, gentle fashion, or getting somebody to understand something, there's an art that comes with it. Not all physicians are the same. They're not all cookbooks. Now, I don't need to tell anybody with a chronic disease that. You already know that. You know that there are certain doctors you like and certain doctors you don't like for various and sundry reasons, and they may not be the same people for everybody. Cost control was put into place utilizing evidence-based medicine. The idea that we should not do anything outside of an evidence-based framework brings about some cost controls, and that brings about managed care. There are some altruistic reasons for managed care, good things for managed care. If we manage care appropriately and sort of weed out the fringe providers, if you will, we can maintain health. Now, maintaining health is a very good thing, but as anybody who knows me knows that I'm a big believer in that as much as you'd like to maintain your health, MS happens. Things like that happen. Cancer happens. You can do everything you want. You can be a long-distance runner like Jimmy Fix and then get a heart attack and die. You can eat special diets with low cholesterol and still end up with cancer. So maintaining your health is a goal. Managed care would like to maintain the quality of their healthcare providers. The question is, how do you determine quality? Is that determined by the population of patients they get? I'll tell you an example of what I'm talking about, a solid example. Would I have been considered a quality provider? Well, by my patients, I'd like to think that I was considered a quality provider. By the insurance companies, not so much. Not so much. I had 3,500 people with MS. They all required a lot of care. I had no cheapies. They all required something. And because I was an MS center, I got the worst of the worst cases as well as the not so bad ones as well. I got all kinds. So I was expensive, and I don't apologize for it. That's just the way it was. So was I considered a quality healthcare provider? Well, by the people who rated doctors in the community as doctors, yes. By the insurance companies, no, not so much. They would like to standardize management. You hear this all the time with diabetes, that if we control the blood sugar, we control this and we control that, we get the A1C this way and that way. Look around, and diabetics are all different, but people with MS are certainly all different. How do you standardize management for a disease that everybody is different in? They would like to help choose evidence-based therapies based on the evidence. They would like to organize the loose ends of medicine. The true endpoint of managed care is definitely cost containment, and this was really brought home to me this last weekend when I attended a meeting put on by the Multiple Sclerosis Association of America. I'm on their health advisory board. I'm on the health advisory board of virtually every organization you can imagine that has to do with MS. And they put on a meeting and they brought managed care to the meeting. And then we sat and had a dialogue. There were probably 20 people in the room, maybe 25 people in the room. I have to say that I had the dialogue with them, it seemed like. I was, because there was a pompous internist who was a doctor, and there were two pharmacists, and they were trying to defend what they do. And it really brought it home to me that this is what they do. And this is what they see themselves doing. They said point blank, we're not telling you how to practice medicine. We don't know how to do that. Our job is to contain the costs. My job, I thought, was to take care of my patients. They wanted me to take care of my patients in the cheapest possible way, and I always thought I would like to take care of my patients in the best possible way. If it happened to be the cheapest, that's great. If it happened to be the most expensive, so be it. We had to do what we had to do. It's all about power. Who's in control? And there's no question who is in control. They said to me, and it brought back all the memories of when I was in practice just instantly. They said, "Doctor, we're not telling you what to do. We're not going to pretend, but we are not going to pay for it if we don't like it." That's all about power. That's about power. Turning medicine into a business to control costs. In the process of this, it makes doctors poorer and administrators more wealthy. And so I said to these folks, well, you're asking prior authorizations on everybody, and that's when the whole meeting erupted because everybody chimed in at that point. Prior authorizations on everything, on everybody. Think about what that means to a physician's office. to have to do prior authorizations? Well, I can tell you that in my office it meant that I shouldn't be doing them because I just lose my temper. I start screaming at the people on the other end of the phone. And I'll tell you why. I'm an educator. I always saw myself as an educator. That's one of my jobs that I do. Educate patients, educate doctors, educate groups. That's part of what I do. I never minded being asked, why did you choose that drug? If I couldn't tell somebody why I chose that drug, something is wrong. Now, they may not agree with the choice, but I should be able to defend that. But I didn't want to argue with a retired surgeon about whether I should be using the drug or not. That wasn't what I wanted to teach them. So I'm on the phone telling them, this is what we do, and they're on the phone telling me that's not what I should do. And what they're saying makes no sense. And when I find out that they're not even a neurologist, it makes even less sense. So I can't do that. So I hire nurses. Well, I had 4 nurses. I had them long before managed care. But they weren't hired to do prior authorizations. They were hired to be nurses. But now they have to do the prior authorizations. That raises my overhead, you see, because now I have to have somebody doing the things that they have to. And so my overhead is rising. Their overhead is rising too, because now they have a network of people calling all the doctor's offices. And where do those people that are calling all the doctor's offices live when they're working? In big buildings. And somebody has to pay for the air conditioning and the rent of those buildings. And somebody has to pay for the salary of this physician to oversee all of these people who are questioning all of these doctors. And so if the cost of healthcare doesn't rise, if it stays stable, it shifts. It shifts away from the providers who are paying more for their overhead, and it goes to the administrators in their offices. And when I said this to this guy, I said, you know, I think you should dismantle the whole thing. Take the buildings down, fire you all, and then the cost of healthcare would go down. Do you know what he had to say to me? He actually didn't have anything to say to me. He couldn't argue against that. I kind of got him dumbfounded there for a minute. Because we've created a network that is just shifting the cost to the wrong side of the equation in the interest of business, if you will. And it's diminishing appropriate health care by making it harder to provide. So here are some facts. 62% of the personal bankruptcy filings each year are related to medical bills. 62% are. The lowest paid CEO on the list of 10 largest nonprofit hospitals earns over $2 million. The lowest paid CEO. Now let me tell you that I started our MS Center in 1976 in private practice. It was the first comprehensive MS Center in the United States in a private practice. And for 15 years we worked with a hospital in Minneapolis together. Separately, but together. Practice was my practice. The rehab services were in the hospital. And after 15 years, I kind of looked at the bookings of everything and said, you know, they're making all the money and I'm doing all the work. So I went to the hospital and I said, this is the case. They knew that. And so we ended up being bought by them. They bought us. So for the next 12 years or so, I was a hospital-based physician with our MS Center, the same center, just in the hospital. When I joined that, I negotiated a contract, and the first year I got a letter from the hospital organization saying that by necessity they were reporting to the IRS that I was one of the top 5 paid people in the hospital. Which I think they said they were sending it to me almost to embarrass me, but it didn't embarrass me because of the people that were paid well, I was the only fee producer. I was the only one bringing in money. The others were administrators. I was one of the top 5. After 4 years, I stopped getting that letter because I was no longer in the top 5. Because their salaries kept going up and up and up and up, so that it got to be almost ridiculous what they were making for what they were doing, and that's just the reality of it. Of the countries that spend the most on healthcare, we spend by far the highest per person, and yet our life expectancy is in the lowest of the group. There are lots of reasons for that. The life expectancy part isn't the part I want to emphasize. It's that we spend a lot per person on healthcare. The money's out there. It's just how is it distributed that makes little sense to me when I think about health care. So managed care in itself, in concept, is not inherently bad. It may help organized health care to prevent repetition and the use of inappropriate treatments. But if it hasn't come to where you're living, it will be there tomorrow. In the past 5 years, it was an interest to me in my latest role of running around the country talking with doctors in their offices about MS and disease management. When I came from Minnesota, where I lived entirely with managed care, I understood all of this prior authorization business and all of the issues that I'm talking about. When I went to Texas, they didn't have any of that. They do now. It's everywhere. But this is managed care. This is not anything to do with President Obama. This has to do with the business of medicine. This is managed care. And people can't seem to differentiate managed care. Managed care from the Affordable Care Act. Managed care determines which DMT you may be on or not as they get more and more powerful. So I see this now all the time, where the managed care organizations decide, well, we've got 4 interferons, we're going to choose 1. We've got this category of drug, we're going to choose 1. And now they're saying, well, we've got a drug for MS, we're going to choose 1, not just in the category. Managed care determines if you can stay on treatment or not. Your doctor might write down, this is becoming more progressive, and managed care decides they're not going to pay for it anymore. The doctor may not feel that way, but managed care has the purses and says that. And if you don't believe that's the way it really works, you're not in the offices. That's the way it really does work when it comes to you that way. They may determine whether you switch treatments. Every year they put out for bids the different pharmaceuticals, and then they decide which one fits best. And now they're getting empowered to say, well, no, we're not going to cover yours this year. You're going to have to switch. Before they said, you're going to be grandfathered. You could take it for, because you were there. Now they're saying, you're going to have to switch or else pay for it out of your pocket, one or the other. Managed care determines if you may go into the hospital and for how long. How many times have you heard? You've got to check to see whether you can go into the hospital or not. It's managed care that determines which drugs for which symptoms you may take. Ampera, maybe, maybe not, depending on the managed care feelings that day. And they do this often through what they call pharmacy benefit managers. These are groups that review formularies and make decisions about which drugs they're going to pay for and which ones they're not. They contract with the pharmacies for this. They negotiate discounts and rebates from the pharmaceutical companies. So at this meeting, there was a tremendous hostility toward the pharmaceutical companies on the part of managed care. I don't know who they thought they were talking to entirely. I mean, we all have certain feelings about the cost of these drugs, but what they weren't saying was, these drugs cost a fortune, and they shouldn't. We all know that. I'll just say that point blank. They shouldn't cost what they cost. But these people don't pay that. They don't pay for it at that rate. They negotiate a price, sometimes a really discounted price, and then they turn around and charge full price. They make a profit out of the deal, and they keep it. It's a sort of a backdoor deal type of thing that makes everybody look bad in a sense. They negotiate discounts and rebates from the pharmaceutical companies. The largest ones, Express Scripts, CVS, Prime Therapeutics, United Healthcare, Catamaran, they're not hurting. They're all making money and building buildings, and they're at the top of the stock exchanges in terms of what they're doing. But what's important for all of us to understand today is that managed care is not the Affordable Care Act. It's not the Affordable Care Act. I went into the drugstore a couple of years ago to get my prescription of a blood pressure medicine that is not generic. It's not generic. Pharmacist says to me, it's going to cost you $250. I knew that because I've been paying for it. He says, that's because of Obamacare. I looked at him and said, Obamacare? I'm on Part D of Medicare. That has nothing to do with Obamacare. Nothing whatsoever to do with Obamacare. And he looked at me and said, I know that. I said, then why did you say that to me? And he said, well, it's just something I say. I mean, it was just thrown off just like that. All of this has become a bit of a mishmash, and it's a purposeful mishmash that makes no sense. Managed care is not the Affordable Care Act, and don't diffuse that. Don't confuse that. The Affordable Care Act came from the Republican side of the aisle. You'd never know that by listening to what's going on today, but this was not a Democratic plan. This was a Republican plan. It came from a conservative think tank, the Heritage Foundation. And when the Heritage Foundation brought this out several years ago before it was made into a law, the Democrats decried it, said this was terrible, they didn't want it. The Republicans all got behind it, said this is wonderful, this gives people the empowerment, this makes people pay for their care so that their money is in the act, that this is a good thing. It's personal responsibility, it's financially sound, it requires all people to have private insurance so that everybody is in the game at the same way, and it's private insurance so that this isn't the government involved. This is a conservative Republican program. It does not significantly change the fundamental structure of how we provide health care. The doctors are there, the insurance companies are there, everything's the same. This was a Heritage Foundation program. The Democrats controlled Congress, but they couldn't get anything else passed, and so they got this Republican program passed. And as soon as they did, we got the Affordable Care Act. 42 million Americans under the age of 65 are uninsured. Healthcare spending is 42% of the gross domestic product. We've had abuses in hospital billing, and this tries to address that. It forces insurance to explain their policies. It insures millions more Americans. It prohibits pre-existing exclusions. It covers preventative care. It eliminates the caps in health care. You can outstrip your insurance quite easily with a chronic disease. It makes plans use money for health care rather than administration. But it costs money. And it's, for some reason, very debatable, and it eventually will cause our premiums to rise. There's no way you can insure people who have not been insured and not cost money. So somehow or other, there's no free lunch. The money has to come from somewhere. If it doesn't come from the government itself, it has to come from us. It's gonna come somewhere. And it leaves managed care in place. So who should we blame for the Affordable Care Act? That's where it came from. It came from Massachusetts. You know, that's where it was. It was put into place, and that's where the conservative think tank, if you will, Republican governor, put it into place. That's not to say it's bad, but who do we blame? We've got things a little bit screwed up in terms of who we blame. So let's look at what this does, actually. It has two real areas. It has insurance reform and health system reform. So on the side of insurance reform, it covers more people, it gives more benefits and protections for more people, and it actually lowers the cost by providing preventative care for lots of people who would let things get out of control. At least that's the goal. On the health side, it's supposed to improve quality and efficiency, make a stronger workforce, and have more focus on prevention. How do we cover more people? Well, part of this was through a Medicaid expansion. Medicaid is the state's programs to cover the people who are at poverty level and can't afford health care. By expanding this to cover more people, we cover more people who have no insurance. We get more people into the health care system. And they wanted to do this through insurance exchanges, where the insurance companies would all compete, and there would be also a federal plan as well. Well, the federal plan, which would have kept the prices down, got shot before it got out of the barrel, so it's gone. So now there are the potential for insurance exchanges, and you have to guarantee health care to people. Covered kids under 26 on their parents' policies, and it was a minimal coverage provision. This gave essential benefits, preventive services, it controlled the rates, and you couldn't run out of it. You couldn't say because you have multiple sclerosis you outstripped your health care abilities. You couldn't, there were no annual limits, and they were pretty uniform. They did this through the exchanges, which looked at medical loss ratios, how things actually were practically done, and developed a premium to do this. There were certain Medicare programs. Medicare has nothing to do with the Affordable Care Act, nothing at all, but there were certain Medicare programs called Medicare Advantage programs. I don't know whether any of you are on a Medicare Advantage program. In my state, as far as I was concerned, there was only one Medicare Advantage program that was worth anything, and the rest of them I hated when people got on them. And people didn't understand Medicare Advantage, and I can tell you President Obama, who wanted to eliminate it, he understood it, but he didn't do a good job of explaining it, of why he wanted to eliminate Medicare Advantage. So I will try to explain that for a moment. Standard Medicare, you get Medicare Part A, that comes to you for being a U.S. citizen, being over 65, or having a disability that qualifies. You get that. Part B and Part D you pay for, and it's based on how much you have, whether you pay for how much you pay for it. And so there's subsidies, if you will, for that. Medicare Advantage comes to you and says, well, we'll take the money that would go to Medicare, that the federal government is giving for you to Medicare, we'll take that into our insurance company. And we'll provide you then with Part B and Part D, the doctors and the medicine. We'll take care of all of that. And for that, the government gave them a subsidy more to do that. Sounds good. Now you don't have to worry about it. You got your Medicare Advantage program. You don't have to worry about services. They're all paid for. Now you get sick. And you get multiple sclerosis, or you had multiple sclerosis, and you decide you need to go to a particular multiple sclerosis doctor, or a particular multiple sclerosis therapist, or a particular whatever. And they look at you and say, no, they're not on our panel. Our panel only has this doctor, and this doctor, and this therapist, and this therapist. Well, so you're stuck. So now you go to their therapist, and you think you have 10 treatments that are authorized, but maybe you need 20. No, that's not going to be authorized because you're under their Medicare Advantage program. Where if you were under the normal Medicare, you could go to the different places that accept Medicare without that type of restriction. So President Obama said, let's eliminate that, let's save the money, put it into the Affordable Care Act, and what did we hear? We're cutting Medicare. You folks out there, we're cutting Medicare to all of you. And really it had nothing to do, it had to do with the Medicare Advantage programs only, nothing else. And yet even when that was explained, it didn't seem to make a bit of difference to the pundits. It was the same kind of comments that went on, Medicare Advantage. And then we had the prescription drug rebates that get involved in the cost of it as well. What they want to do is have accountable care organizations to watch over special homes, if you will, that have specialty diseases so that they could have quality measurements and develop particular payments. So this managed care fellow said to all of us, what he would like to see is that for multiple sclerosis, a neurologist with a comprehensive care center would say, I've got 3,500 patients, and they'll say to you, well, we're going to give you $1,000 per patient. I'm making up these numbers. $1,000 per patient per year to take care of them. So obviously it would be more than that. But so then I would rake in that money, and then I would divvy it up the way I would see, because now I'm in the dance here. I'm involved in this. And at the end, if there's money, I get to keep it. And if there's no money, I'm in trouble. I go out of business. Does that remind you of something that we saw back in the 70s? We called it capitation. Capitation, where that's the insurance plan where people were given money to take care of a population of patients, and it didn't work because everybody went out of business. It was a back to the future type of event. I can't, it doesn't work, it won't work, and it would provide me with the opportunity to say to you, you don't need that physical therapy because now I've got my food on the table versus your food on the table. It puts us in a very inappropriate circumstance to deal with. So, by providing more care and standardized care, we could maybe take care of more people and have better public health as well. So most individuals and families would have minimum essential coverage, and if they didn't, they'd have to pay a penalty. And the way that they would be able to pay for this care if they don't have it is through subsidies. The government would give them the money to do that because that's the only way you're going to get health care paid for. So that in the end, it shouldn't be a basic harm to you. But it was portrayed in such a way as to make it more and more difficult for people to understand that the end was to get more people covered. And large employers still covered people the way they always did. They had to offer minimum essential coverage to full-time employees. And of course, during the recession, everybody blamed this for the reason for the recession, even though the recession was worldwide, that people had no more full-time employees. They're all going to part-time employees, so they didn't have to do this. But you understand what we're talking about when we're talking about the Affordable Care Act is only 25% of the population, not the rest of everybody. It's only a small minority, but it makes it sound like it's huge. So through expanding Medicaid, by having these competitive health insurance marketplaces and insurance reforms, and leaving these individual employer mandates, the employer mandates, and getting individuals to have to buy insurance, we could have more people insured. But the states had to say whether they were going to go for the exchanges themselves, have their own exchanges. And so this is the map I'd like to draw your attention to. The red states decided not to have exchanges. They're bastions of health care, if you look at them. That's where the health care is the best in the country. My tongue is in my cheek. Texas, which has the most poverty and the worst health care, doesn't want it. Louisiana, Alabama, Arkansas. You know, it's amazing. The places where they could benefit the most would not take the money from the federal government to put this plan in. All based on the fact that it's perceived as a Democratic plan, even though it really is a Republican plan, not based on any reason or logic that makes sense to me. But to have a plan, to have a bone in this game, so to speak, the insurance companies have to jump through certain hoops to make their plans qualified. Before we got into the Affordable Care Act, I always said very publicly, I said, you know, we have a lot of uninsured people in the United States. A lot of very uninsured people, but we can get them help. We can work through the welfare system, through whatever, churches, etc. Excuse me, to get them help. I worry about them, but I worry more about the people who come to me with insurance. And then the insurance doesn't cover this, doesn't cover that, doesn't cover this. They think they're insured until they go to use it. And then they find out that they're really not insured. I worry about that because that's a surprise. They've been paying their premiums, and then when they go to use it, they find out it's not really valid. So to keep that from happening, the government said, you have to have a qualified health plan. It has to cover essential benefits at a particular level and must include essential community providers. And then you can be included into this plan. But if you insurance company, have a plan that's not qualified, you can grandfather it in as long as you don't change the plan. But that's not the way insurance companies work. Traditionally, what they do is they sell you those plans. And then a year later, they sell you a different plan. And a year later after that, a different plan, because that's how they make their fees. That's just the business model of it. So when they came up for renewal, when they went to sell you another plan, it wasn't qualified. It didn't grandfather. If you have your insurance, you could keep it. All of a sudden, we were told that was a big lie. Actually, it wasn't a lie. It was but they changed the insurance plan. It wasn't the same insurance, and it wasn't qualified. And so when they came through with the next plan, as they did before, they raised the rates on it. People went bonkers, and they blamed the Affordable Care Act. If the Affordable Care Act hadn't been there, they would have come through with the next plan, they would have raised the rates on it, and you would have been swearing at the insurance company, but now the insurance company says, it's not our fault, it's Obama's fault. Most insurances may not deny coverage because of pre-existing conditions. They should be correcting the mistakes of simple paperwork problems. They shouldn't have lifetime caps on essential coverage. They were charging women more than men. They can't do that anymore under the Affordable Care Act. The preventative services have no deductibles. And the coverage is effective immediately for also things that are of some ethical concerns to certain people, including birth control services. The problem is that we didn't get rid of managed care. What the Affordable Care Act did was leave the insurance companies in place. That was the old Republican Heritage Foundation plan. Leave the insurance companies in place. So who really ends up benefiting in the end out of all of this? The insurance companies still get the last laugh. They get more people involved, and then they start squeezing the rates, and then they start blaming the government for that. So what does this mean to you as an individual with multiple sclerosis from a practical standpoint? And I figure I've lost a ton of you in this mishmash of the insurance. But what this means when you get down to it is when you go to see your doctor or your healthcare professional, your visit starts out with not, how are you feeling, but with, can I see your insurance card? And when they look at your insurance card, that sets up a whole nother sphere of, well, do we get this service or that service? Can we do this MRI or that MRI? The decision-making changes directly based on your insurance. No card, maybe no service. The healthcare provider looks at the insurance and then develops a plan of attack even before the interview. The insurance company has formularies, drugs they will cover, drugs they won't cover. Sometimes they're known to us, and sometimes they're not known to us. I can tell you lots of stories about that. So then we do a history and examination, and then the plan of attack is established. And then the arguing starts. Decide I want to have this drug or that drug, and I've got to deal with the managed care phone call, with the paperwork. I have to argue with their experts, or my staff does. That's not what I signed up for, really. And then the laboratory studies must be okayed. I'll never forget when I walked out of a patient's room to hear my receptionist talking with one of the managed care outfits about an MRI. In Minnesota, they had just decided to prior authorize every MRI. All the companies had at the same time. They don't talk to each other, but they all did it at the same time. Interesting how that happens. And so my secretary is talking to them. I walk into the patient's room and I come out 25 minutes later and she's still talking to him. But she's ending the conversation. And her conversation, I heard the end of it. She said, well, now that I know what you want, next time when I call, I'll just tell you what you want. And then this conversation won't have to be 20 minutes. And the person at the other end of the phone said, no, it's going to be 20 minutes. And my receptionist said, well, why should it be 20 minutes? And the person at the other end of the phone said, because it's supposed to. Why is it supposed to? Well, maybe we'll stop calling because we don't have that kind of time, and maybe we won't get that MRI. And then who loses? Who loses? The patients lose. It makes no sense. And so there's more arguing that goes on. And you need to obtain whatever from managed care sources in the network. All of this raises the overhead and the cost of the visit. There's no way it cannot do that. And so the costs go up. And so, but they fix our reimbursement. So you folks get a bill for $300 from the doctor, and you say, wow, that's 20 minutes, that was $300. But the fact of the matter is the doctor gets 30. I'm making up these numbers. But that's the kind of thing that we talk. So we raise our rates to $330 and we get 30. It doesn't matter what we say, we get what they give us, and that's what we have to take or not take it at all. The result is a loss to the provider. The providers then have to cut the time to appointments so that they can see more patients so they can make that up, that loss. And you feel it in every office that you go to. You cannot help but feel there's been a change from the way it used to be. Things have to move because you have to see more patients. Whoa, whoa, Dr. Goldfarb, please slow down. You're getting way ahead of the insurance paperwork. Gee, I always thought that said Medicare.
Mediocre.
So, how do you get what you need and keep it? Pick a good doctor, pick a good physician, and a good office staff, if you will. And then squeak, because the squeaky wheel gets the oil. Squeaky wheels get the oil. Understand the process and get involved. If it's managed care that needs to be called, you call too. Get involved. Give it a human face to it. Don't just put it all in the doctor's office. Stand up for yourself and help. Utilize the company's help services, whether it's pharmaceutical companies or whatever. Every company has their help services for Rebif. It's MS Lifelines for Beta Seron. It's Beta something plus or something. We need to change the system. Get your congressperson to govern instead of being so partisan. Govern. Take this out of partisanship, and let's put together. We're spending enough money. There's enough money in the program. We could have a decent program. Act to improve the issues. Change these lobbying programs so the insurance companies aren't always the winners on every time we turn around. There are things that we can do. And if you want a second opinion, I'll call my wife. So we turn on the television, and what do we hear? Obamacare fails, Obamacare this, Obamacare that. You never hear anything good because that's part of the system that we're in. It's not fix it, just complain about it. I might be seeing that from that standpoint as well, but I'd like to fix it. I don't have the power to do it, but I'd like to do it. And I think it's fixable. That's the part that bothers me the most. With age comes skills. It's called multitasking. I can laugh, cough, sneeze, fart, and pee all at the same time. Thank you all very much.